I have the power, but yes, recording in progress. So talking about the transition to adult neurology and looking at the participants in this room, I can see that there are a number of people who are adults living with neuromuscular conditions who will presumably have been through this transition process. And if we've got time at the end, I'd love to hear some of your experiences with that. I've put this picture up here because this is the aquarium at the Royal Children's Hospital in Melbourne. And this is the fish pond outside St. Vincent's Neuromuscular Clinics. And I actually think this is really representative of what it's like to go from the pediatric neurology world to the adult neurology world. And we've certainly got a lot of work to do. In terms of where we are at the moment, we've had this real shift, particularly in the last decade, and even more so in the last 5 years, where we now don't think about diseases of childhood, but we think about a lot of diseases as beginning in childhood. And actually 12% of young adults in Australia have a chronic condition. And 90% of children now who have a chronic condition or a disease process will reach adulthood. And this is significantly improved from what it used to be with the changes that we've had in access to treatments and therapies. So this means that more and more children are moving through to the adult health system. And as much as it shouldn't have, it has kind of caught us unawares with the volume of people who are transitioning through. And it really does reflect around 18% of the Australian population. And so some of you in Victoria will know we've got meerkats at the Royal Children's Hospital. And I was asking one of the young men who comes to my neuromuscular clinic about his thoughts on the transition process. And he said, it's not as well coordinated. And I must say, I love it when my patients are blunt with me because I'm not going to know otherwise. But I was kind of aware of that. It's not great. And this is the historical reasoning why it's been like that. So adult neurology clinics have sort of sprung up from all of the individual specialties that happened over the years, and they're often not multidisciplinary. As many of you will know, there are very few formal multidisciplinary clinics across Australia. I know Gayatri Jain at the Austin does have a respiratory physician in her clinic. I don't in mine, it's just neurologists. There's rarely a nurse or a coordinator, and that's very much around the funding model. So a lot of the public hospital clinics are either public funded or MBS funded. And an MBS funded clinic means that the neurologist is paid to do a session, not paid to really do anything outside that session. And then the hospital will bill Medicare an item for that particular consultation. And for a person who's coming for the first time, the hospital will get back $230. And for a review, it's $115. So by the time you think about paying the administrative staff, the overheads, paying the neurologist to come for the session, there's not a lot of money left over from the funding that's given to the clinic to pay for a nurse or for a coordinator. We used to be able to get some of these positions funded through industry, but with the changes to the legislation around interactions with industry now can no longer fund anything that's salary. So it's really been quite limiting. And often it's been specialties have had their dedicated days. So neurology was always a Tuesday, and some of the other specialties were always on a set day, and it's really difficult to move those clinics to becoming coordinated and streamlined. And one of the biggest barriers is actually space. So my new stroke clinic is a Friday afternoon. What a terrible time to have a clinic on a Friday afternoon. But the only reason it's on a Friday is because it's the only day when there were rooms still left in clinic to physically run the clinics. You will be given an appointment time. Sometimes if it's a privatized MBS clinic, that will be a little bit more to the time you're given. A lot of public hospitals still run these cattle yard clinics where even though you'll be given an appointment time, your file gets put in a box at the back of the clinic and the next available doctor takes the file from the front. And if it looks like it's a thick paper file or a complex one and it's a junior doctor, I can tell you they'll go for the easier files. So I'm not saying that's acceptable. I'm saying that that's the reality of it. And that's why sometimes you'll get there and your appointment's 2:30 and it's 4 o'clock and you're still sitting in the waiting room. There'll often also be conflicting commitments for the doctors in the clinic, and they'll be on ward service as well, or they'll be trying to manage sick patients on the ward. So they may be running backwards and forwards between the clinics at the same time. The other thing that's quite different is that if an appointment is missed, nobody rings up and says you missed your appointment. It's just kind of up to that person to know somehow that they've missed their appointment and tried to get through to rebook. I rang the Ionia Hospital the other day to try to rebook a patient. I was number 40 in the queue. So we're aware that there are a number of challenges, and particularly the transition from pediatrics to adulthood. Young adulthood's a really challenging time without having a neuromuscular condition. It's when young people are really developing their sense of independence and a keen desire for autonomy. And that's really, it's hard enough without needing to take into consideration, what do mum and dad still have to do for me? Am I dependent on somebody to get onto public transport to go out with my friends? And then with the increasing health needs that come with getting older as well. So it's a challenging time. So why does getting transition better actually matter? There's an evolving degree of literature and scientific evidence around this process. And what's now understood is that if we get transition from pediatrics to adult care right, there's an improvement in survival. People actually report better quality of life on objective measures of quality of life. There's a clear reduction in anxiety levels. There are less medical complications, and there's an improved engagement both with the community, with life, with social and work activities, and with autonomy around managing health affairs. So it's really important that this doesn't fall off our radar as a priority. As much as we want new treatments out there, we need the processes whereby these treatments can continue to be delivered. Oop, too far. So what does a neurologist actually do? This is the women that I work with, and most of these are actually have an interest in neuromuscular diseases as well. Some of you will know the professor in the orange dress, Professor Katrina Reardon, who's been at St. Vincent's for many, many years, and an excellent neuromuscular specialist. So just to give you the background for how we get to where we are as a neurologist, because not everybody is aware of this. So we spend usually 6 or 7 years at medical school. I did a 6-year course at Monash. Now it'll often be an undergraduate degree in science or biomedical science, and then a shorter medical degree of maybe 4 years. Then you do a year as an intern, which is your junior doctor's sort of year in training. Then you go on to 3 years of what we call basic training, where there's a breadth of education around all of the different subspecialties within medicine that don't include surgery. Then if you are successful in passing those major exams, you can apply for advanced training. It's a competitive process. And then it's another 3 years of advanced training specialty in general neurology, where you get some introduction to subspecialty training. Then you can call yourself a neurologist. After that, you start to subspecialize. Within all of that, most of us who end up as adult neurologists will have had maybe 3 or 4 months training in pediatrics and maybe 3 or 4 hours training in young adult medicine, let alone how to transition and the issues associated with transitioning from pediatric to adult care. There's different categories of what we're called. So staff specialists, that's a more common model in New South Wales, where the doctor's employed just by the hospital. But a lot of people, particularly in Victoria, visiting medical offices, where you come and you do your session. So you'll see patients in that clinic, and then you go and you might work at several different hospitals. Subspecialisation is sort of where most of neurologists sit now. There's very few generalists because subspecialties have become so complex that it's too hard to do them all. So your neurologist may have a couple of subspecialty interests. So for example, I work across neuromuscular, stroke and headache. My PhD was in stroke, but I'm now doing a lot of work in the other specialties as well. And then within that, your neurologist may have a further particular interest, such as being an academic neurologist, where they really work at understanding the scientific side of things. They might be involved in research, be it in the laboratory or clinical research. They might be purely clinical and only see patients, or they might have appointments with the university and be involved in education and training as well. So there's no sort of one model of what a neurologist looks like. So that does influence then how your neurologist may look after you with a neuromuscular condition. And there's been in the last, a few years, more of an understanding about the role of the neurologist as a care coordinator for people living with neuromuscular conditions. And I actually really like this this quote that there should be a multidisciplinary approach. It should be coordinated by one of the physicians, generally the neurologist or pediatric neurologist, who is aware of the disease course and potential issues. Because a lot of neuromuscular conditions can be rare or difficult to manage. They can be complex, and even as neurologists, we may not know a lot about them to start with, so it's difficult to expect other clinicians to understand them. And so we really have a number of different responsibilities as neurologists in helping the people who come to see us to look after their health, to maximize their health and functional capacities, to make sure we're looking at the disease course and progression, preventing and being preemptive around the complications, and then really making sure that for each individual, we're following evidence-based care so that everybody, no matter where they live, has equity of access to the best standards. And that's challenging because in some cases we don't have evidence-based management, and in some cases that there's a inequity around the capacity to supply evidence-based care, or there's a lack of consensus amongst neurologists as to what that care should look like and how it should be delivered. We have an emerging role in promoting access and advocacy, and also in advising other disciplines. So when we're working together, that might involve interactions with rehabilitation specialists, the orthopedics, psychologists, the cardiologists, and the lung specialists, which we've heard about this morning, nutrition, and then putting all of those together, obviously with the patient at the centre. And it can be very difficult to navigate the public health system if you're not aware of what the back end looks like. And I'm sure a lot of you have had experience with that. Particularly advising other disciplines. It's really important. I get really frustrated when my patients come back to see me and they go, oh yeah, I was admitted to hospital for 3 weeks. I'm like, well, why did nobody tell me? I get so annoyed at that. And it really does need to be better communication between the clinicians, because there'll be things that I'll want to communicate if my patient is in hospital. I do often get called by an anaesthetist if one of my patients with a neuromuscular condition is having surgery, which is really good. And sometimes we need to liaise about medications. So people who have muscle conditions that cause a high CK, I'm often a little bit nervous about starting statins for cholesterol therapy, and we might need to talk about alternatives. Vaccinations have been a big one. I haven't had any of my patients where a vaccine has been contraindicated, particularly for COVID-19. But I've had a number of other specialists ring me and saying, is it all right for this person to have their COVID vaccine? And invariably, my response has been yes. And one of those roles that was on the previous slide was around the diagnosis and genetics. And this was mentioned earlier in the presentations today as well. That we have very different access to diagnostics, even again in the last couple of years. Genome-wide sequencing and the genetics panels are constantly evolving. We have a great relationship with the team at PathWest, and they have a number of neuromuscular panels that we can order when we're looking to establish a firm diagnosis. And it really is important that we do this. A lot of people have had their neuromuscular diagnosis determined by a clinical examination because we didn't have the technology in the past. And they've gone forward with a diagnosis that may not actually be correct. And so if we can genetically characterize a lot of these conditions now, it gives us a better understanding of what to expect for that person. So we can look at the predicted disease trajectory. We can then start about really individualizing treatments and therapies. We can then particularly, and perhaps really importantly, look at clinical trials. And a lot of the clinical trials that are coming through require a genetic diagnosis. It's also important to have the correct diagnosis so that we can get access to testing and try and cover the costs of that as well. And there are different types of testing that are available, and they have different costs, but your neurologist is often able to walk you through how to get access without being thousands of dollars out of pocket. Moving on to the physical assessments, and this again is something that is evolving. Many of you will have experienced going to your neurologist, and that it will be, so is there anything different from the time I saw you 12 months ago? And you just go, oh yeah, not really. And that's about the extent of the consultation. And in the past, these more formalized assessments of physical functioning haven't really been routine or a standard of care. And part of the reason behind that has been this reluctance wants to continue measuring physical assessments when the expectation is that there will be a slow and steady decline, and not wanting to say, yeah, you've declined from last time. And so a lot of people have felt that it wouldn't necessarily change clinical management. So these standardized assessments haven't been done, but now they are recommended. And we're just starting to work out which assessments we should be doing routinely and for whom. And it really does make a difference in us making sure that we're applying standard of care. We know quite strongly now that physiotherapy can slow disease progression and prevent complications. Paying attention to stretching and positioning and mobility and the need for chest physio is really important. And the neurologist now has a responsibility to ensure that this part of neuromuscular disease care is being addressed. And on this slide, I've put just a number of different outcome measures that are now being they've been validated. So they've been shown to accurately reflect the physical condition. And you can see we have dedicated ones for FSHD. There's the revised upper limb module for SMA. The motor function measure is a generalized score that will cover and be appropriate in a number of neuromuscular conditions. Many of you will have heard of the North Star ambulatory assessment, which is used for Duchenne. There's the Hammersmith scale, which is also SMA. And then there are a number of timed tests which give us a clue about fatigability, about the muscle strength, and a whole lot of other features. So things like the 6-minute walk test or the timed up and go test. And we really should be working with the people coming into our clinics and saying, okay, well, this testing has been shown to be appropriate in this situation. What do you think about us routinely adding this into your clinical care? In a lot of situations, these assessments are better done by neurophysios. Some of them require a bit of equipment that we often don't have access to in the neurology clinic room. And with the NDIS access, there's actually a much better opportunity for us to work with the neuromuscular physios who are being seen through the NDIS funding and get them to do these assessments. So it's a collaborative approach. But perhaps more importantly, are patient-reported outcome measures. And this is another big shift that we're looking at. So we're trying to be more accurate than just saying, how do you feel, but recognizing that what a person is experiencing must be part of the clinical assessment. And so this table is from a paper where they surveyed over 1,000 people who were living with neuromuscular diseases and asked them what their top priorities are, because often you get somebody into clinic and the priority of the neurologist may not necessarily be the priority of the person who's come for the appointment. And so they asked about how much difficulty people were having with different functions, and these were the top ones. So difficulty with weakness and fatigue were really, really common. And then difficulty with walking and difficulty with sleeping and understanding those things. And they're not necessarily something that was getting addressed routinely. There are now also a number of validated outcome scores that we can use to objectively track how people are feeling in response to their therapies and treatments. And one of the reasons that this is important to start being a standard of care as well is it keeps us accountable. So we can then look back at our own data and go, well, all of my patients are scoring really poorly on quality of life measures from their patient-reported outcome measures. What are we doing wrong? What do we need to fix? Or everybody's scoring really highly. What are we doing that's associated with this that we need to keep doing? So it's really important for that accountability of care as well. What about each system? So we've heard a bit about heart and lungs today. So my approach with heart care is that I do the stuff that I'm comfortable with. And whenever I meet a new patient, I will often do a baseline cardiac workup. Unless it's a neuromuscular condition where we are 100% confident that there's no cardiac involvement, I'll often do a baseline ECG or Holter monitor, which is the 24-hour ECG, and an echocardiogram. Some of the neuromuscular conditions, like some of your central core myopathies, we might be a little bit more proactive in looking for cardiac complications, and I'll monitor that. And if I start to see anything that's out of the ordinary, then I might refer on to a cardiac physician So that's Associate Professor David Pryor sitting in the centre there, and he's actually a neuromuscular cardiologist. And we have a neuromuscular cardiology clinic now here at St. Vincent's. And I'll usually get them to coordinate the medications if there's a need for cardiac MRI or cardiac devices. But if they're then happy the person is stable and they might only see them every 2 or 3 years, then I'll watch those things in between as an additional link to making sure that cardiac care is under control. Similarly, for lung care, I'll often do the baseline testing myself. Every patient of mine with neuromuscular conditions will have lung function tests at least once, and frequently a sleep study as well. And that's because the lung muscles, the diaphragm, the intercostal muscles, so the muscles that sit between our ribs, they're muscles, and they can be affected by neuromuscular conditions. And again, then if I start to see problems or concerns there, then I'll refer on to a respiratory physician where they can work at looking at the role for physiotherapy if a person needs non-invasive ventilation, if they need nocturnal ventilation, so breathing assistance at nighttime. So most of your neurologists will be quite happy to monitor the basic things, and if they're not, maybe they should be, and it's okay to give them a nudge and say, well, do I need a lung function test? And if they say no, ask why not. Bone and muscle health is now moving up our list of priorities for what we should be watching for as neurologists, up into the importance around the same as heart and lung. And that's because we're now understanding that in a lot of neuromuscular conditions, the way that the bones and the muscles talk to each other is disrupted. And that can be through a number of different biochemical processes. But the ultimate outcome is an increase in bone fragility. And as a lot of people lose their ability to walk properly or to do significant weight-bearing exercises, that can also increase the risk of bone fragility. We like to throw around steroids a lot in neuromuscular conditions. And again, this can increase the risk of osteoporosis or fragile bones. So when we're seeing that, we're then wanting to make sure that we don't have a group of people who have fragile bones, have poor mobility, are at a high falls risk and are likely to fracture or damage their bones. So we're most of the time now recommending a yearly DEXA scan, and depending on what the outcome of that DEXA, which is a special bone X-ray scan, and depending on the outcome of that, you may be able to push that out to 2 or 3 years, but checking vitamin D levels, and there's a number of other bone turnover markers that I will now routinely do for my patients who are non-weight bearing. And when I start to see concerns around that, I'm referring on to the metabolic bone clinic much sooner than we would have in the past. So we're no longer waiting for people to become osteoporotic. At the first sign of problems with bone health, we're jumping on and saying to our metabolic bone colleagues, who are typically endocrinologists, can you help us out here? And in the last few years, there's been a significant amount of new drugs come onto the market that really promote bone health. Some people will have had their bisphosphonate infusions or their zoledronic acid, but there's a lot more that have come out now, which has come from our understanding of bone health in elderly people, and it's now being translated forward to understand how this is important in younger people with other conditions. The other picture that I've got down the bottom there is muscle MRI. And this is something that I think in the next few years is probably going to creep into clinical practice. It's currently mostly in research, but what we know about neuromuscular conditions is that as they progress, there's often what we call fatty replacement of the muscles. And this happens in SMA, in FSHD, in Duchenne, a lot of these conditions. We see the muscle tissue starts to disappear. So it's atrophy. That's where the word atrophy comes into some of these diagnoses in the name of the diagnosis. And it's replaced by fat. So as I go across the screen, this is a pretty mild case. You can see some white stranding in the muscle here. This is a leg. And as we go across, there's more and more white. This muscle here has now narrowed quite a lot. So it looked really nice and big before, and now it's quite shrunken. So we'd say that's atrophy. And by here, you struggle to tell the difference between where the muscle is and then the fat in just our normal fatty tissue. And that's what we call fatty atrophy or fatty replacement in the muscles. And there's some thought that this might work as what we call a biomarker for disease progression. And the pattern of muscle involvement varies across the different conditions, and it can sometimes be used as a way for us to actually diagnose conditions, is the pattern of muscle involvement. other conditions, with the increasing aging in neuromuscular conditions, we want to be thinking about preventative health. My favorite thing, preventing stroke, preventing heart disease, making sure everyone's had their immunizations. Those other conditions of aging, we're all getting older. And the joint pains and the all of those sorts of things as well. Making sure people have an emergency plan. So we often talk about asthma management plans and that for children, but we don't talk about emergency plans enough for people with neuromuscular conditions. What happens when you get a cold or the flu? What happens if you end up in hospital because you've got appendicitis? And thinking through surgical management so that if you are in an emergency situation where you're about to have surgery, you know what the anaesthetist needs to do. Contact this person, do this, avoid this drug. And then also thinking through for advanced care planning. One of the great things with some of the change in legislation is it's opened up for conversations a lot more, and it's actually a legal obligation for a clinician to ask if you have an advanced care plan. And this is to ensure that your decisions around the care that you would like in the event that you couldn't speak for yourself are taken into consideration. And this is important for people who might have more severe forms of their disease. But certainly I have an advanced care plan. I don't have a chronic condition, but I do have an advanced care plan about my wishes, and so does my mum. And you can also nominate a medical treatment decision maker, and that doesn't have to be a family member or a relative. And you can make that then a legal document that goes onto your medical record. And it's the neurologist's role to make sure that people are informed about this and to help guide through this advanced care planning stage. So what about access to treatments and trials? So a lot of these newer drugs that are coming on, we heard Monique speaking about a lot of that earlier on today, are going to be, your neurologists are going to know about them first. Your tertiary hospitals are going to know about them first, because that's where the clinical trials are going to end up. So sometimes there will be medications that are developed and there's really not a lot yet in the adult space, but they'll actually say that only a specialist can prescribe them. So Spinraza or nusinersen for spinal muscular atrophy, it can only be prescribed by a specialist medical practitioner in a neuromuscular clinic. And that's actually the ruling around getting access to it. Even one of the new headache medications for migraine that has just come out can only be prescribed by a neurologist. Pre-approval access will come through neurologists. So at the moment, I have about 8 people who are about to start nusinersen treatment. Even though I can't get access to it on the PBS, I have access to it through a free access program, so I can get people onto it sooner. We get that earlier access to pipeline drugs. So it's another reason to really engage with your neuromuscular specialist. And what about things that are happening at the moment? There's not a lot happening in Australia for adults. It's really, really disappointing. And the more that we have consumer engagement with neurologists, the more that we can get clinical trials to come to Australia. And I know we harp on about the registry a lot, but it's really important because the first thing that drug companies do is they look to see how many people they're likely to be able to recruit to their study. And if there's not enough, they'll go to the bigger countries like America. So what's happening for interventional studies? So there's some other observational things happening, but interventional. So this is your drug trials where they might be saying, this person gets the drug, this person gets the placebo or the dummy drug, and we're comparing the two for effectiveness. So there's one study for inclusion body myositis, which is being run. It's a phase 1 clinical study run in Adelaide and Perth. So that's a safety study, not really an effectiveness study. There's a couple of studies with new drugs for Friedreich ataxia being run. I think they're both at MCRI and one of them's in a few other places. I can't remember right now. There's several motor neurone disease studies, which Monique mentioned as well. It's not as common as a lot of these other neuromuscular conditions, but lots of studies there. And there's one study looking at nusinersen in SMA for adults, but that is for people who are already on nusinersen. And then all of these other conditions, FSHD, myotonic dystrophy, Duchenne, CMT, limb-girdle muscular dystrophy, oculopharyngeal muscular dystrophy, myotubular myopathy, Bethlem, congenital muscular dystrophy, there are currently no clinical trials for drug therapy or treatment in Australia recruiting adults. it's really frustrating. But this is again where I feel quite strongly it's the role of the neurologist to advocate for access to that, and just a reminder that the registry is really one way that we can do that. So I've left 5 minutes for questions. I'm going to stop sharing my screen. All right. Did we have any in the chat?
Yes, Sharon asked a question about when a patient has numerous chronic illnesses, who should you get to treat or coordinate all the specialties rather than trying to find your own way, which is very stressful?
Yeah, I agree. It is super stressful. I must say I usually talk to my patients about that, and we come up with a plan together. So I have a lot of my patients have a number of different conditions going on as well. And then it tends to be whichever one is the most dominant condition for that person, that tends to be the specialist who helps to coordinate the care. There's no one size fits all, and I think it's an important conversation to have with the neurologist and ask the question, who's actually running the show here? Because it's hard for it to actually be the person navigating the system for themselves a lot of the time.
Lauren, there's also a question about how to get a diagnosis if you haven't yet got a diagnosis and you're an adult.
Yeah, so I think it depends on what the provisional diagnosis is, and that certainly will guide the way that we go about diagnosis, whether it's a predominantly a muscle condition or a nerve condition, or where the nerve muscle condition, neuromuscular junction condition. There are a number of genetic testing panels that can be done now, and so it's worth asking your neurologist at your review, are there any new ways for me to confirm my diagnosis since the last review? And just prompting that question. Sometimes we need to restain the muscle biopsies. So sometimes we recall them and we have another look at them. There's a few different ways about it now, but it's guided a little bit by the phenotype, but genome-wide sequencing, there's a whole lot of things. And if it's thought that it's a genetic condition, particularly if there's a strong family history, going through a genetics clinic can also help to access diagnostic approaches.
Thanks, Lauren. There's a question about what else can patients do to encourage medical trials amongst adults in Australia outside of joining the domestic and international registries.
Yeah, it's really challenging because in all honesty, most of these things come from outside Australia. So it is about being linked in and encouraging neurologists to advocate as well. And asking your neurologist, who else is doing this? Do you know? Can you find out? I mean, a lot of my increased involvement in SMA has come from my patients pushing me to do it. So, they've been the loudest group so far. So that's where, you get involved. It's hard, going through politicians. Usually they don't have a lot of sway. We do need to get the numbers, and working with your neurologist, I think, is probably the best way.
And I think the last question, Lauren, is actually a recommendation, if there is a recommendation about a neurologist in Sydney, which might be tricky.
Yeah. So there's actually a few neuromuscular specialty clinics in Sydney. All of the neuromuscular specialists in the dedicated neuromuscular clinics in Sydney would be fine to manage limb-girdle muscular dystrophy. So I think if you get your GP to refer you specifically to a neuromuscular clinic, I know all of them there, the clinicians there would all be right to cover that.
Okay, I think that we need to go back to the main.
Can I ask a question?
Thanks. It has to be very quick. I think we'll get thrown out of the room in a minute.
Yeah.
Yes.
Sure. Yeah. I know that there are many types of muscular dystrophies, and this session has been more about the muscular dystrophy. So my question is particularly about myotonic, and I'm just wondering, like, how worse can a myotonic muscular dystrophy can go up to, and are there any treatments, and what kind of support we can get from various organizations?
Yeah. So all of the concepts that I've spoken about today actually apply across all of the conditions. And I think it is, I saw there was a website put up, the myotonic dystrophy.org, was it? So that's a great website to have a look at. Talking to your GP, and again, there's not a lot in the pipeline in Australia at the moment with regards to treatments, but liaising with your neurologist and making sure that you have regular reviews is a really good way to go about it.
Okay, thank you so much.
We'll need to wrap it up, but thank you very much, Lauren, for a really valuable session. I'm sure that people were able to take quite a lot of from the session today. So we'll need to leave the breakout room and return to the main room.
And I'll try to reply to everything else in the chat.
Great. Okay, thanks very much, Lauren.
Thanks, everyone.